do a little introduction here. So I'm Steve Avila. I'm with the National Scoliosis Clinic. I'm joined by our CEO, Dr. Michael Gardner, and of course, our guest of honor here, Megan Glenn-Castile. She is the founder of Scolios-Us, an assistant professor at Baylor College of Medicine, and an orthotist with the Align Clinic.
Hi guys, I'm happy to be here. Okay, I'm going to go ahead and share my screen. We'll see if we get this right. All right, can everybody see?
Yes, looks great.
Good.
Perfect. All right. So like Steve said, my name is Megan Glenn-Castile. I wear a few different hats in the scoliosis world. So I'm a certified orthotist prosthetist, and I practice up at Align Clinic, which is a scoliosis specialty clinic. So actually about 95% of what I see is actually pediatric scoliosis. I'm also an assistant professor at Baylor College of Medicine, and here's one of my students. So at Baylor, I lead a lot of research projects that are once again centered around scoliosis. And then I'm also the founder and the president of Scolios-Us, which is a nonprofit designed to empower scoliosis patients and healthcare providers treating them. So what we're going to talk about today, we're going to talk about bracing, and then we're also going to touch on the psychological side of things. Because although bracing biomechanics is one of my passions, we also have to pay attention to the patient as a whole. Now, if you're on this webinar, you probably already know what scoliosis is, but just as a reminder, scoliosis is the sideways curving of the spine that measures at least 10 degrees. So there are different causes of scoliosis. You know, you can have a congenital change in the shape of the vertebral body that a patient is actually born with, so that would be congenital scoliosis. You can also have neuromuscular or syndromic scoliosis, which are caused by certain conditions. But then the majority of the scoliosis that we're seeing in clinic is actually idiopathic. So this means that we don't exactly know what causes the spine to start to go sideways on us. We're getting closer to finding out some of the answers as to what's driving this, but ultimately we still really don't know what it boils down to. And so that's why it's still called idiopathic scoliosis. Here are some examples of what scoliosis looks like. So you can see different presentations here. Sometimes the trunk gets shifted over to the right, sometimes over to the left, just depending on the patient's presentation and their curve patterns. Of course, some curves can be smaller, and it's always great when we catch them when they're smaller because they tend to be easier to treat. But some curves are just really darn aggressive and they tend to progress to a larger magnitude, like in the second and the last picture here. Now, our treatment options are really based on the size of the curve or the Cobb angle. So curves that are under about 20 or 25 degrees are typically observed or treated with physical therapy. Now, once we go over that 20 or 25 degree mark, all the way up into about 45 or 50 degrees, that is really my wheelhouse. That's where we come in with bracing. We find that when patients are growing, the brace tends to be an essential piece of the puzzle to keep that curve in check and to grow our patients as straight as they possibly can. And then what we find in the literature is that curves that are over 50 degrees tend to continue progressing over the lifetime. And so those curves are typically treated with surgery at that magnitude. Now, if we start talking about bracing for scoliosis, it's really important that we establish the goals of bracing. So with bracing, our goal is to reduce the size of the curve or the Cobb angle in brace in order to prevent the curve from getting bigger out of brace. So if I have a patient who comes into my office with a 30-degree curve, if they are 12 years old and it looks like they have a few years of growth left in them, by the time they get done growing, I ultimately want them to be no more than 30 degrees out of brace. Now, of course, there are certain cases where there are just certain circumstances that make patients respond better to bracing. We still don't know exactly what those are, so it's hard to predict it up front. But you can occasionally get some out of brace correction. But I would say it's very, very, very rare, almost impossible that you're going from 30 degrees all the way down to 0. We might see a curve go from 30 degrees to 27 or 25. Small increments like that. But ultimately, with our braces, we are trying to prevent that curve from getting bigger once the brace comes off. And so we're going to touch on bracing biomechanics. So all braces, regardless of brace design, operate on 3-point pressure systems. So what does that mean? In order to straighten out any curve, we have to push at the curve, but then we also have to push above and below the curve in order to get the leverage to actually straighten the curve out while in the brace. So if we look at these 3-point pressure systems on some actual x-rays, of course, the curve over here on the left is bigger than the one on the right, but the 3-point pressure systems would operate in the exact same way. You're going to push at the curve, and then you have to push above and below it. And we're going to touch on brace designs. But again, regardless of the name of the brace, it really just comes down to biomechanics. And beyond that, it also comes down to who is actually fitting the brace and who is manufacturing the brace. Because your manufacturer and your orthotist really need to be experienced and know what to look for so that they can be applying these 3-point pressure systems appropriately. So I would say focus more on the biomechanics versus the actual name of the device. So the Boston brace is one of the most common used brace here in the US. So this brace, it's a symmetrical design, and then the correction is going to be achieved with padding. So where we're putting those pressures against the spine in that 3-point pressure system, that's going to be done by adding pads into this symmetrical device. The traditional Boston brace opens in the back, but some of the newer versions now incorporate straps in the front. Now, the Rigo Cheneau style has been very popular in Europe for a long time, and I would say in the last decade or so, it's really gained a lot of popularity here in the US. So the concepts behind a Rigo Cheneau design, basically we have 4 goals. We're going to try to elongate the spine, derotate the spine, correct the cob angle, and then correct the posture as well. Like I talked about earlier, sometimes the posture can shift from the left to the right, depending on the curve pattern. And so we're trying to accomplish all of those things in Rigo Cheneau braces. This is an asymmetrical design as opposed to the symmetrical design like the Boston. Traditionally, it opens in the front, and then the correction is actually going to be achieved in the brace itself. So no longer with paddings, but now it's actually in the plastic, the pushes. Some variations here in the US, the wood Cheneau Rigo is what my clinic, Align Clinic, specializes in. But there's also the Ortholutions RSC design and then the NYRC brace as well. All of those are different variations on the Rigo Cheneau concept. Now, the Providence brace is one of the 2 nighttime braces that I'm going to introduce. So by its name, the Providence is nighttime, so we're only going to be wearing it at night. So about 8 to 10 hours, ideally each night. It's always great when it's summertime because we find that our kids tend to sleep a little bit more, so they get closer to that 10 hours. But realistically, during the school year, I'm happy if our patients are getting about 8 hours in the nighttime brace. Now, the correction in these braces are going to be achieved again with padding. And in the Providence brace, the emphasis is on derotating the spine. The lever arms are really long in these nighttime braces because the patients aren't having to sit and go to school and do their everyday activities in it. And because of that, we can just leave the brace a little bit longer without causing any discomfort or any trouble for them. Now, the Charleston bending brace is another nighttime design. It again, like the Providence, is going to open in the front. But while the Providence focuses more on derotating the spine, the Providence focuses more on unbending the spine. So it's that overemphasized 3-point pressure system. And the idea is to overcorrect the spine in order to get away with only wearing this brace for about 8 hours a day. Now, once we actually fit the brace as orthotists, I always say that's about step 2 in the process. We're really just getting started. After we get the fitting done, we have to go ahead and do an in-brace x-ray. Typically, the in-brace x-ray is done, I would say, about 2 to 6 weeks after our patients get fit with their brace. The reason for this is we want to give their bodies enough time to actually adjust into the brace and be wearing it full time. This makes sure that what we're seeing in the in-brace x-ray is accurately reflecting what the brace is doing for their spine. And it's not just at the beginning of them getting used to it. Now they're used to it, and what we're seeing is what we're truly getting. And this is one of my patients that we've tracked over time here. You can see in her first brace that she got in July of last year, we got pretty good in-brace correction. Posturally, we made some really good improvements here. And so in her out-of-brace x-ray that she had this past January, our cob angles are relatively similar, but you can see the postural shift and she's becoming more balanced. But what's really awesome is in this May x-ray, when she got her new brace, now we're getting even better in-brace correction. So that's what we can see happen with younger patients. Now, the opposite can be said for older patients. As patients get closer to skeletal maturity, typically the spine just isn't quite as flexible. So say I'm fitting a kid who's 12 years old. They get awesome in-brace correction. Well, then a year and a half later, they're 13, they're getting closer to being done growing. We get a new brace, we get a new in-brace x-ray. We might not see the same amount of correction just because their spine isn't quite as flexible as it was a year and a half ago. And that's completely okay. So talk with your orthotist about realistic expectations before heading into this in-brace x-ray. Now, some frequently asked questions about bracing. So the first is, how long does a brace normally last? It really depends on our patient's growth. So I always tell my patients that they're going to be growing, but their brace isn't going to be growing with them. And so it really just depends on how quickly they grow. That then determines how quickly we need a new brace. So I would say on average, a brace should last about a year or so, sometimes a little bit less, sometimes a little bit more. But I would say we can typically accommodate about 3, maximum of 4 inches of total height growth. The next question I often get asked is, does bracing hurt? And the answer should be no. I always tell my patients, we're going to be pushing against their spine, but those pushes should feel like handprints, not finger pokes. So if there are any pinpoint areas of pressure or redness that does not fade away, blisters, bruising, none of those things should be happening with a brace. So if that is happening, I always encourage people to go back and talk to their orthotist and see what we can change. And then, this is the question that I always get at the initial evaluation appointments. How long do I have to wear my brace for? And again, it just depends on how much growth we have left. When a kid is growing, that's when their curve wants to grow with them. And so that's why we have to wear the brace, again, to literally grow them as straight as we possibly can get them. Once they get done growing, then we get to come out of this thing slowly. I always tell my patients that the whole goal of bracing is to get them out of their brace. And so it just depends on how much growth they have left. And we use different markers of skeletal maturity to be on the lookout for determining how much growth we do have left. Now, the effectiveness of bracing. So the brace study, which was published in 2013, was one of the most groundbreaking pieces of research that we have in bracing history. So this was a randomized controlled trial. And what they had 2 groups. They had one group that got braced and then one group that was only observed. What they found was that they actually had to stop the study early because bracing was found to be so effective. So they said that continuing with the observation only group was actually unethical. And what's really fascinating was that in the bracing group, 90% of the subjects who were wearing their brace for 13 hours a day or more were actually able to avoid surgery. So that shows us that wear time is really important. But because wear time is so important, adherence is also a very common problem that we're facing and a source of a lot of the discussions that I'm having in clinic. We have the research to back this up too. So there was a 2003 study that found that patients wear their brace for about 75% of the prescribed time. I've seen some more recent studies that are actually a little bit lower than that. And then there was another study that took place at a very well-renowned scoliosis institution, and it found that only 15% of its subjects were actually wearing their brace for 14 hours a day or more. And so we know that adherence is something that we really need to pay attention to. If wear time is impacting effectiveness so much, like it clearly is, we have to be paying attention to making sure that our patients are wearing their braces as they should. And that leads into our next topic, which is the psychological side of scoliosis and bracing. It's not just a matter of not wanting to wear the brace. There is a lot of psychological burden that comes with a diagnosis of adolescent idiopathic scoliosis. We know from the research that patients with AIS consistently demonstrate altered mood, and that's most notably depression and anxiety. There was a 2018 study that was done by Dr. Sanders that found that pediatric scoliosis patients present with similar anxiety rates as pediatric cancer patients. And that's really crazy to think about because we would never put those two conditions in the same bucket, but they're presenting with very similar rates. And so we have to pay attention to this. And there was an earlier study that found that adolescents with scoliosis are actually 40% more likely to develop suicidal ideation. So these are really serious things that we need to pay attention to as healthcare providers. And there's this quote that I really like from this study in 2018. It says, as a disease of adolescent onset, AIS causes superficial disfigurement at a particularly vulnerable time for psychologic development and identity formation. And it's so true. And then we add a brace in, and it's just a whole new ballgame. Bracing really just adds this extra layer. And our brace patients have revealed that bracing actually causes more stress than the actual diagnosis. And it can evoke feelings of stress, anger, and shame. And then we also know that brace patients tend to suffer from diminished body image. But there are things that we can do about this to help our patients feel more comfortable and supported through the bracing process. And one of those things is social support. So social support has been found to be really beneficial for our braced patients. There are several studies that have found that it can improve adherence and then make patients just feel more comfortable going through this. And we actually did a study last year. Hopefully we'll be publishing it soon, but we asked, how important is it to have social support? And we asked our subjects who were all adolescent idiopathic scoliosis patients, and most of them are saying it's extremely important to know somebody else who is going through a similar thing as they are. And so that's where we arrive at Scolios-Us. So one of the big features of Scolios-Us is we actually run a mentor program. So we connect kids with someone who knows exactly what they're going through. And we have mentors on both the bracing side of things and on the surgery side of things, so that whatever our patients are facing, they can connect with someone who knows what they're going through, who knows what it feels like. I can tell my patients to wear their braces they should until I'm blue in the face, but I never wore a brace myself, so I truly don't know what that feels like. But getting connected with someone else who does know, I mean, that can be a really powerful experience. And now we've also added the option where, say, a kiddo doesn't feel like they want to be a mentor or a mentee in the program, that's totally fine. They can just join the group as a group member and still connect with other kids who are going through the same thing as they are. And so like I talked about at the beginning, what is Scolios-Us? So it's a nonprofit organization intended to empower scoliosis patients and the healthcare providers treating them. And so our homepage is bracingforScoliosus.org. And there's a ton of different information that can be found here. One of the main features of the website is we compile over 50 scoliosis specific resources into one page on the website. And that's not just a tool for patients, but also for healthcare providers. So you know, as a healthcare provider, if you're referring your patient to this one website, whatever they're looking for, whether it's a scoliosis support system or scoliosis blogs, braced piggy bears, whatever the case may be, they can find it here. And then we also run our mentor program. We have a blog. We have a ton of evidence-based information about bracing, x-rays, physical therapy and exercise, all kinds of things on the website too. So it's really meant to be a resource for you guys. And looking forward, we have some really great ideas that hopefully we can bring to fruition. So we have been doing some research where we're incorporating clinical psychologists into the bracing protocol. And so we want to be able to offer that on a larger scale. So hopefully if we get a grant that we are applying for, we can bring that to fruition. And then we also want to develop an app. Even with Scolios-Us compiling all the different resources onto one page, patients still have to go out and kind of explore those themselves. And so what we want to do is at that initial appointment with their doctor, they can download the app and go through a series of questions and see which resources are going to be best for them at the very beginning. So kind of taking the work away from the patients and setting them up for success right from the get-go. And I know we're going to have some opportunities for questions, but I will pass it over to Dr. Gardner to introduce the National Scoliosis Clinic.
Thanks so much, Megan. That was really, really awesome. Really just succinct, helpful, clear overview of some of the pertinent issues with bracing. And so we're really excited to partner with Scolios-Us and Megan. They've really done some great work and have just a wealth of incredibly useful information. So just a brief overview of the National Scoliosis Clinic. We know that receiving a diagnosis of scoliosis, adolescent idiopathic scoliosis, is stressful and overwhelming. And so we're seeking to put together all resources that families might need. So in addition to information, and again, Megan has a lot of great information on her site, we offer telehealth consultations with scoliosis doctors via telehealth, some office hours for live discussions with bracing experts like Megan, also physical therapists for educational consultations, and also guided physical therapy programs that have been shown to help decrease progression of a curve and even sometimes reverse the curve. And then finally, peer support with other patients as well. The final piece is that we're working on a technology that allows a scan to be done, a three-dimensional scan on a smartphone to assess the severity of scoliosis, to be able to track how severe the scoliosis is, correlating to the Cobb angle from home, frequently without radiation. And so that's going through the FDA process now, and so it's not available and still in research mode, but coming soon. And there's a beta version for people who are interested. So this is some of the things included in the membership. It's launching this week or next week. So head over to nationalscoliosisclinic.com, and we're having a sale right now on the membership. But again, thanks, Megan. So why don't we open it up for questions? And we have a few if people want to start putting some things in the Q&A box.
Yeah, we had received a number via email ahead of time for people who couldn't join the webinar. So I'm happy to kick us off here with a couple of those. We got one asking, what is insurance coverage like for braces?
Ooh, good question. So they tend to be pretty good in terms of covering braces. I find that if we get pushback, it tends to be on the first brace. And then once we get the first brace approved, insurance more or less knows that it's just going to be a matter of time before we outgrow it and need a new one. Now, some of the newer designs use a different code, and sometimes that one code can get a little bit of pushback. But for the most part, I would say they tend to be well covered. So it's just a matter of if you've met your deductible and all of that fun stuff.
Thank you. All right. Are braces effective when someone is past their growth spurt?
Do we mean like fully skeletally mature?
It didn't give any further context by
Okay.
beyond that.
Yeah. Okay. I will answer two parts of that, I guess. So I have braced several kids who are getting very close to being skeletally mature, but are not quite there yet. And I have found that to be very successful, especially if they have postural imbalances. Because at that point, yes, we're stopping potentially some curve progression, although we probably don't have a ton of risk for curve progression if we're almost done growing. But what I do find is that it's used as a training tool for them to also help and get them back into a better alignment, so that officially when we're done growing, then we can maintain that good alignment, head out into adulthood, and hopefully stay nice and balanced. Now, if we are completely done growing, I typically recommend that patients try physical therapy first, because where bracing really comes in is maintaining that corrected posture while the kids are growing. Of course, we cannot think about our posture 24 hours a day. It's impossible. Whenever I start talking about it, I sit up nice and tall, but realistically, we're not doing that every day. And so that's where the brace comes in, to biomechanically force the patients more or less into this corrected position. With physical therapy, they learn how to do that with their own muscles, and that's something that they can do forever and ever going forward. So if they're already skeletally mature, I typically start with the physical therapy route. Now, I find that that tends to take care of a lot of pain that patients might be facing, which is why they typically present to me that first time. I will say sometimes after adults go through menopause or start to see some of that degeneration happen in their spine, they may start to get a little progression and pain in their spine. And so then they might come back to see me. Again, we start with physical therapy, but if they need just something a little extra, then we will go ahead and try to brace them. With adult bracing, there aren't clear guidelines like we have with pediatric bracing. And so a lot of times I start off as minimal as possible and then kind of move up from there. If we can get by with a flexible brace, fantastic. I'm going to send those patients on their way. But if that's not quite enough, then we can move on to something that's more aggressive, like a rigid brace, if the patients are on board with that.
Right. And just quick follow up on that. So how often, in a situation like that where it's not clear, how often do you need to check the efficacy of the brace, how it's working, and then how often do you need to adjust braces?
Yeah, that's a great question. So in my normal pediatric population, I'm seeing them every 3 months to do a follow-up. And in those follow-ups, I'm checking their height, their weight, their clinical rotation, because I want to make sure that that's not increasing on us. If it's increasing, then what I tend to find is that the curve also tends to be increasing. So if that's happening, we want to make sure we can reassess, add some padding, change some things around if needed. Ideally, we want to see that stabilize or even go down. So I'm doing all those things every 3 months. And in doing so, I find that I typically pick up on the kid outgrowing the brace before they start having discomfort or any curve progression or anything like that.
All right, we're getting some questions from the group now. I would say for the first one, maybe we'll back it out a little bit and say, how do you identify who is a good candidate for braces?
Yes.
For bracing. Yeah. How do you identify a good candidate for bracing?
And I'm assuming we're talking about pediatrics?
Yeah.
Yeah. So if we cross, I would say about 20 degrees for the cob angle and our kiddo still has growth remaining, then they're indicated for a brace. I would say sometimes, depending on physician preference, we wait till about 25 degrees. But if they have a strong family history, if they have a lot of clinical rotation, then even at 20 degrees, we'll go ahead and get started with bracing.
And what's the best way to identify if someone has growth remaining?
A few different factors. So we'll look at some of the growth plates in their hips. The Risser sign is the most commonly used, and that's a growth plate on the top of the hip bone. It tends to be captured in the normal x-rays for scoliosis, so that's why we're able to look at that. We also use one that's a little bit lower in the hip called the triradiate cartilage. If that's open, then that means that our kiddo hasn't gone through their peak growth yet. They haven't gone through their growing like a weed phase. If that's closing, then they're growing like a weed. We know that they're really growing rapidly, and it's really important that we get them braced as quickly as we can. If we start to see the Risser sign pop up, which is on a scale of 0 all the way to 5, once we get to about Risser 1 and 2, they tend to be past their peak growth, but they're still going to be steadily growing until they plateau around Risser, I would say 4.5 or 5. And then we also use menses. So typically us girls, we stop growing about 2.5 years after we first get our period. Now that's only one piece of the puzzle. So I always tell my patients that we're not going to exclusively use that because everybody's different. We'll use that in combination with other factors. And then of course, age. And one of the techniques that's been gaining a lot of popularity and tends to be more accurate than the Risser sign is actually using a hand x-ray. So physicians will order a hand x-ray, and that's called using the Sanders scale. And that tends to be a really good marker of how much growth we have left.
Great.
Do you work with patients who have scoliosis from non-idiopathic or neuromuscular, and what's the role of bracing in that patient group?
Yes, we do. I would say most of my population is idiopathic, but we do have some that are congenital or neuromuscular or syndromic. And in those cases, we have to take them on a case-by-case basis. And we more or less have to treat the patient in front of us. Sometimes we're just trying to delay surgery as long as we can. In some conditions where the curve is really aggressive and really strong, we just know that no matter how hard we push in our braces, we're just not going to stop it. So we might want to just accommodate that curve and hopefully delay surgery. I hate the phrase brace failure, because even if patients, no matter what the cause is, if it's idiopathic or syndromic or neuromuscular, whatever the case may be, even if we end up having to have surgery, the brace gave us the gift of time and the gift of growth. If we can push surgery down the line until we're more skeletally mature, until we've grown more, and hopefully make surgery itself easier, I don't think we should call that a failure. I think it's just one step in the treatment process with a brace.
All right, great. How about nighttime bracing in that neuromuscular group? So next part, follow up to that question.
Yeah, I don't typically find that we use nighttime bracing too much in that population. There are certain cases, of course, like say a patient can't tolerate a daytime brace, or they have like behavioral things that are going on as well that make it just really difficult to wear a daytime brace. I absolutely think that a nighttime brace is better than nothing for sure. But I will say sometimes the daytime braces actually offer postural benefits for those patients as well, and just make it easier for them to be more upright, be able to eat better, interact with family, friends, classmates, things like that.
Awesome. Next one in here, maybe I'll just comment. So there's a question, are there online support groups for teens with scoliosis? I would say yes. So at the National Scoliosis Clinic, we've got the ability to talk with other patients. And also Megan's got a really at bracing for Scolios-Us .com, right?
.org.
.org. Also a really good online support group for teens. So I would say those are some of the resources out there. It can be very helpful. And then comment on the next one that I'd love your take as well. So Schroth therapy, more and more data that it's effective. Insurance historically has been difficult to get approval for, although it's improving, but again, just depending on the insurance plan. And so we actually have a Schroth therapist who can guide some exercises. There's also some other non-Schroth scoliosis specific Pilates, for example, and we've got a great online library of Scolio Pilates with Karina Thecken. We're onboarding that soon. But Megan, what do you tell patients and families on the effectiveness of both bracing and therapy, or one or the other?
Yes, so I love Schroth. I think it's absolutely fantastic because, scoliosis is inherently out of our patient's control, but that Schroth therapy gives them some control back over their bodies. And I think that alone is very empowering for them. Then we add in, of course, it can help with curve progression. It can make them more symmetrical. And these are all things that patients can see. And I think they really value being able to see the changes that they're making in their own bodies. But when patients are growing, once they cross about that 20-25 degree mark, we find that Schroth alone needs to be combined with bracing in order to keep that curve in check. Curves that are smaller than that, we can try with just Schroth to see if we can keep it under control. And a lot of times we absolutely do. But just in those more progressive cases where the curve just continues to increase, then we have to incorporate bracing with it as well. Like I said, with my Rigo Cheneau braces, everything that I'm doing biomechanically with the brace is what Schroth is teaching you how to do with your own body. And so I really think they work really well together, and I always recommend it. I know the insurance side of things, well, I hate talking about that and having to deal with that, but unfortunately it's a reality of the situation that we're in. So a lot of times if it's not covered by a patient's insurance, I'll recommend or suggest that if they can, just go for a few visits and take just a few nuggets of information that they can hold on to. And hopefully as more and more data comes out about Schroth, the insurance providers will start to jump on board with it, because I think it's a really valuable service for our patients.
Yeah, awesome. And that's really helpful and interesting, that kind of from an ancestry of biomechanical philosophy, Rigo, Cheneau, and Schroth are kind of the same principles. And so they're very complementary to each other and kind of meant to go together.
Absolutely.
To Deb, so Debbie asked about a recording. Yeah, so we'll be sending the recording to everybody who signed up. And then the question, does the firmness or softness of a mattress have any impact on scoliosis?
Ooh, I haven't seen anything that has linked mattress firmness to scoliosis. I will say when it comes to bracing and mattresses, sometimes the really soft mattresses can be a little bit more uncomfortable, which I know seems counterintuitive, but just the firmness of the rigid brace in contrast with the very soft mattress can sometimes be a little bit problematic, but honestly, I would say sleeping in the brace tends to be the easiest part. So it's pretty rare that I have a patient who has a hard time sleeping in whatever condition.
Awesome. How about TLS, kind of standard TLSO braces? Do they have a role in scoliosis?
Again, I think a standard brace is probably better than nothing. But when we're talking about scoliosis, we're talking about this three-dimensional change in body shape. And so we really need something that's customized to optimally push against that curve and give us the best correction. You know, if I'm putting a kiddo in a brace and they're putting in all of this work to wear their brace like they should, I want to make sure that it is absolutely the most effective brace that it can possibly be. And so I try to make it as customized as it possibly can be. Now, I will throw a little asterisk on that. If we're dealing with a very large neuromuscular curve or congenital curve, in some cases, it's just very rigid. And so you really can't correct that curve much. And so you might be using more of a standard custom TLSO to hold that curve in place.
Very helpful. Thanks. So maybe last one here. Is what about specific activities that kids can do in a brace? Can they play the piano? Can they play some sports, or what kind of limitations does it have for a daytime brace?
Yeah, so I typically recommend that for all sports, they go ahead and take off their brace just because they're going to be more comfortable and because I want them working out those muscles when they're out of their brace too. But in terms of everyday activities, they should be able to do just about everything. It's funny, in the last week, I had 2 kiddos send me a video of them doing like somersaults on their bed, which again, I would not typically recommend doing, but they were super proud that they could do it in their brace. So like general, I mean, anything where they're just going to be sitting, so like piano or things like that, I think they should be able to do that in their brace. The first few weeks, it's more so just a matter of trying to figure out how to do the same things in a slightly different way. Like, for example, when they're bending down to pick something up off the floor, they might have to bend more at the hips than what they would do traditionally, just because it is going to keep them in a nice upright posture, but that does take a little bit of their normal movements away, but they adapt very quickly.
Excellent. So maybe we'll wrap it up here. Megan, really can't thank you enough for joining us. We're also partnering with Megan's team and mentors at the Align Clinic, who are hosting office hours, kind of a Q&A session. So come over to nationalscoliosis.clinic.com and please visit bracingforscoliosus.org for support groups, ton of great information, app coming soon. So really excited to see as this continues to grow.
Yep, and I'm putting the links in the chat for everyone to see for both the National Scoliosis Clinic and for Scolios-Us, Megan's organization.
Yeah, thank you all so much for having me.
Thanks a lot.
Great
Yeah, have a great day. And thanks everyone for joining. Really appreciate it.